everybody. Today I'm privileged to introduce Dr. Janin Alant. She's an exceptional hematologist, and she's actually the head of Department of Genetics at AMPATH in the moment. And she completed a master's degree in genomic medicine through the University in Cambridge. I think she's the only person with this qualification in South Africa, so it's really a privilege to have her with us presenting this presentation. She's also got a special interest in translational genomics, precision oncology, and pharmacogenomics. Janin, thank you so much for presenting. It's a big honor.
Thank you, Michelle, and thank you for the kind introduction. So, I've been asked to talk about pharmacogenomics, which I have to admit is a topic I've grown to love. It wasn't love at first sight because initially pharmacogenomics can seem very complex and overwhelming. And it's a concept that really wasn't even around when we were being taught as undergraduates, even as postgrads. But that has certainly changed now, and I think most of you would have at least heard of pharmacogenomics. And so my aim tonight or today, this morning, is actually just to show you how you can now make use of this new tool in clinical practice in a meaningful way. So my talk will have two parts. The first part, I'll just ease you into the topic, tell you what pharmacogenomics is, show you some of the terminologies we use, and I'll show you some of the evidence that supports the benefits of this type of testing. And in the second part, it'll be more practical. So how do you decide which patients to test? How do you decide on a test or a testing laboratory? What do you do with those results that you get back, etc.? So please feel free to interrupt me if I need to explain anything a bit more clearer. I'm happy to do so. Okay, so humans have over 20,000 different genes. And genes are basically just sequences of DNA that contain the instructions that the cells in our body need to know how to make essential proteins like hormones and enzymes and transporters. So these strings of DNA are compacted and packaged together in chromosomes. And these chromosomes are housed in the nuclei of every cell. And we inherit two sets of chromosomes, one set from each of our parents. That is nature's clever way of ensuring that there's continuous genetic diversity. And it also ensures a backup system. So if there's a mistake in one set of instructions, there's another copy to fall back on. And then collectively, all the DNA in all the cells, both the protein coding and the non-coding regions, are referred to as the human genome. So humans actually share remarkable amounts of genetic similarity. 99.9% of our DNA sequences are exactly the same. But that 0.1% where it differs actually equates to potentially more than 3 million differences from one person to another. And that is what makes every person on Earth unique. Unique in appearance, unique in their susceptibility to certain diseases, and also unique in the way that they respond to the medications that are used to treat many of these diseases. So pharmacogenomics, or pharmacogenetics, as it's also sometimes called, basically combines or studies this relationship between human genetic diversity, drug response, and efficacy. So it combines the science of drugs or pharmacology with the study of genes and their functions, or genomics. And pharmacogenomic testing then aims to identify those unique genetic changes that can be used to predict a patient's risk of developing an adverse drug reaction, and that also be used to predict genetically which medications the patient is more likely to respond to. So for the purpose of this morning's talk, I'm going to focus only on the inherited genetic changes that can be used to predict drug response. But acquired genetic changes, or tumor pharmacogenomics, is also a very important and rapidly evolving field. And strictly speaking, they can also be grouped under this big umbrella term of pharmacogenomics. But tumor pharmacogenomics deserves its own dedicated talk, so I won't be talking about any of that this morning. So traditionally, prescribing follows a one-size-fits-all approach. So every person has started on the same first-line medication at more or less the same starting dose, which they then may or may not respond to. And this often results in patients experiencing unpleasant side effects leading to poor compliance and reduced efficacy. Pharmacogenomic testing aims to eliminate this trial and error approach by identifying the most appropriate treatment for each patient at the right dose for them from the outset. And this is actually one of the first examples of precision medicine or personalized medicine. It's believed that around 98% of patients will have at least one genetic variant that affects how they respond to a medication. And for many disorders, approach is actually desperately needed, as can be seen here. So around 38% of patients do not respond to the first SSRI that they are prescribed, and this worsens as you go down this list. So we know that there are also many non-genetic factors and external factors that also influence drug response. But it's believed that genetic variability alone accounts for between 15 to 30% of individual variability in drug response. And for some medications, it's as high as 95%. So the proposed benefits of pharmacogenomic testing goes beyond just fewer side effects and more effective treatments. In many conditions, there's also significant potential cost saving, not just in reducing doctor and hospital visits and reducing the cost of managing adverse drug reactions, but also in patients regaining their health sooner, returning to work quicker, and just having improved quality of life. Okay, so today there are more than 200 genes known to be involved in drug metabolism, and collectively these are known as pharmacogenes. So pharmacogenes can be involved in pharmacokinetic or pharmacodynamic processes. So when a patient takes a drug, it needs to travel through the body to its targets, act on its targets, and then be eliminated from the body. And so it's the first and the last of these steps that are under the control of pharmacokinetic genes. So this is essentially what the body does to the drug. And the cytochrome P450 gene is an important example of that. And pharmacodynamics is what the drug does to the body. So these are genes that encode for drug targets like receptors, also genes that are involved downstream from drug targets, genes involved in the actual clinical outcome of the treatment being given. These are some of the common examples of pharmacodynamic genes. So pharmacogenes can be involved in both intentional on-target effects, which produce a desired therapeutic outcome, as well as unintentional off-target effects, which result in side effects and adverse drug reactions. For some medications, like the fluoropyrimidines, a single gene has a predominantly predictive effect, in this case DPYD. So any function-affecting variant in DPYD is highly predictive of fluoropyrimidine toxicity. For other medications, more than one pharmacogene is involved, like for warfarin, both CYP2C9 and VEGF-C1 needs to be tested and interpreted together when assessing warfarin response. In fact, 2 additional genes have now been discovered to also impact on warfarin response. So it is important to know that there are still many medications for which there are no reliable pharmacogenomic predictors. This cannot be used for all medications. Steroids, for example, aspirin as well. So it is important to know which medications have pharmacogenomic information and guidelines available before recommending one and taking this type of testing. The pharmacokinetic genes are often described according to a metabolizer status. You'll see terms like poor, intermediate, ultra-rapid metabolizer being used. And this has a different impact depending on how the drug is administered and how it works. So if the drug is administered as a pro-drug, like codeine is, a poor or an intermediate metabolizer will take a lot longer to convert that pro-drug to its active metabolite, which means the drug will be less effective, and there's also a risk that that pro-drug can accumulate and cause side effects. And on the other hand, if a patient is an ultra-rapid metabolizer, they will convert to the active metabolites a lot quicker. It means the drug will be effective, but they have a much higher risk of adverse reactions like respiratory suppression in the case of codeine and tramadol. That's also why there's a black box warning for these 2 medications, especially in children. And then if a medication is administered in its active form, like omeprazole is, a poor or intermediate metabolizer will take longer to deactivate that active compound, which means the patient is exposed to the active metabolite a lot longer and have a higher risk of side effects. So these patients would generally require a lower dose. Whereas an ultra-rapid metabolizer will deactivate that drug a lot sooner, so the drug will be less effective unless a higher dose is prescribed to attain the same therapeutic efficacy. And that is basically the principles on which this works. So it's important to know that the frequency or the prevalence of certain pharmacogenetic alleles differ according to geographical location and within certain population groups. So this is a geographical representation of the CYP. It's a reduced function CYP2C8 allele that is known to be a lot more prevalent in African population groups. So Africa has a very high degree of genetic diversity and is still underrepresented in pharmacogenomics research, as you can see there by all those white areas on the map. And that remains a huge challenge today, though there are now many large-scale efforts underway to address this gap. Okay, so let's look at some of the terminology. Genotype. So genotype just refers to the actual genetic makeup of each gene in each gene pair. So you heard that you inherit 2 copies of every gene, one from each of your parents. If both those copies have exactly the same DNA sequence, then you're homozygous for that version of the gene. If there's a slight difference in the sequence of the one gene compared to the other, then you're heterozygous for that version of the gene. Genotyping then just refers to the testing that is done to determine what combination of genes you inherited from parents. Then phenotype refers to the observable characteristic or the actual clinical feature that occurs as a result of the genotype. And as I mentioned in pharmacogenomics, it's often described in terms of metabolized statuses. So genetic variability can occur through multiple mechanisms, but in pharmacogenomics, generally one of 2 ways, either a single nucleotide polymorphism or a SNP, or copy number variation. So a SNP is basically where there's a change in a single nucleotide within that DNA sequence. In that example, there's an A at position 3 compared to a C at position 3 in the other gene. And that is a SNP. Depending on where that SNP sits in the DNA, can have a different impact on the enzyme. You can either increase the function, decrease the function, or have no effect whatsoever. And then copy number variation refers to the number of copies that you have of a gene. So in most cases, we have only 2 copies, but with some genes, CYP2D6 especially, people can have many additional copies. In fact, as many as 13 additional active copies. And these patients are then ultra-rapid metabolizers. Opposites can also happen where there's a loss of 1 copy of CYP2D6, known as a deletion. These patients will then have a significantly reduced enzyme function or even complete absence of CYP2D6 enzyme, depending on whether 1 or both copies of the gene is affected. You'll see pharmacogenetic variants often described as star alleles. So an allele is just a version of a pharmacogene. The star 1 allele is the reference version or normal in quotation marks version of the pharmacogene. And then as new versions are discovered, new numbers are added. So an allele can be made up of just 1 SNP or 2 SNPs in combination, as shown there. And then, as you know, we have 2 copies of every gene. So 2 potentially different alleles in combination. That's referred to as a diplotype. And in this example, it's a star 2, star 3 diplotype. So both these alleles in combination then result in the ultimate phenotype, metabolizer status. And then you'll often see additional information on where exactly the SNP is located, what effect it has on the amino acid. I don't think that any of this is important for you as long as you remember that an allele is just another version of a pharmacogene. Some of them have increased function, others have reduced function, others have the same level of function. So a lot is said about the potential benefit of pharmacogenomic evidence. So let's look, or testing, sorry. So let's look at some of the evidence supporting that. So clopidogrel is an antiplatelet therapy, as you know, and it's often used in patients to prevent stent thrombosis after percutaneous coronary intervention. Clopidogrel is administered as a prodrug and is metabolized by CYP2C19. So patients who are poor or intermediate metabolizers take a lot longer to convert that prodrug to its active form. which means clopidogrel will be less effective in these patients and have a higher risk of stent thrombosis. The alternative antiplatelet therapies like prasugrel and ticagrelor are not affected by CYP2C19, but they're a lot more expensive and they have a higher bleeding risk. So a lot of research has gone into determining whether you can use CYP2C19 genotyping to identify those patients who should rather be started on alternative antiplatelet therapy as opposed to clopidogrel. And that's exactly what this meta-analysis did. So this was published in the JACC in 2021, and they looked at 7 randomized controlled trials, just under 16,000 patients altogether. And the authors concluded in the end that the selective use of alternative antiplatelet therapy in patients who have loss of function of their CYP2C19 enzymes, compared to, in addition to a selective use of clopidogrel in patients who have normal function or increased function, results in a clinically significant reduction in bleeding risk, while avoiding the increased risk associated or increased risk of ischemia associated with just giving clopidogrel to everyone. And this has led to many countries, including the UK, now implementing preemptive CYP2C19 genotyping for clopidogrel resistance in the NHS. And just as an interesting side note, the island of Hawaii, 30% of the population is believed to be CYP2C19 poor metabolizers. And the state actually took the manufacturers of Plavix to court for what they claim was a failure to warn patients of the risk of this drug being effective for them. And they were actually awarded damages to the amount of $960 million just last year, the largest court-ordered award in the state's history. So this is another landmark trial known as the PREPARE trial. This was the first of its kind looking at preemptive panel-based pharmacogenomic testing as opposed to just the single drug gene test, like the clopidogrel example. And so this trial was done across 7 different European countries, across different areas, primary care, oncology, general medical wards. They enrolled just under 7,000 patients altogether, and then half of them received personalized prescriptions using an assay that tested for 12 different pharmacogenes. And that test allowed for the personalized prescription of 43 different commonly prescribed medications, statins, opioids, SSRIs, and others. So they followed these 2 groups up for 15 months. And in the end, they were able to show that the genotype guided group, the control group, had a 30% reduction in clinically significant adverse drug events. And they're continuing to follow up these 2 groups to see what the long-term benefit is in terms of compliance and clinical outcome. And then in South Africa, evidence is also slowly emerging, although it's still lagging a bit behind the rest of the world. But this was an interesting study published in the Journal of Personalized Medicine about a year ago. And these researchers looked at the prescriptions issued at Steve Biko Academic Hospital, specifically for those 43 PREPARE drugs. So they saw that 29 of those medications were also commonly prescribed at Steve Biko. And together they amounted to just over 695,000 prescriptions for a 4-year period from 2018 to 2021, and a total cost of 33 million rand. And these were the most commonly prescribed medications: analgesics, cholesterol-lowering agents, and tricyclic antidepressants. And then, interestingly, the anti-cancer and immunosuppressive therapies made up a lot fewer of the prescriptions, but the cost of these 2 together was about almost half, about 17.9 million rand. And they also looked at the number of adverse events reported to SAPRA for that period. It was just over 2,200 reports, and these were the top 5 most reported medications. It's interesting to see atorvastatin and simvastatin there in the top 5 most reported medications, and they were also the top 5 most prescribed medications. So already there is a valid case emerging for the potential benefit of doing genotyping for anti-cholesterol agents in South Africa. And tramadol was the most commonly prescribed analgesic. We know tramadol is metabolized by CYP2D6, and sub-Saharan African populations have a higher prevalence of loss of function of CYP2D6 enzymes. So yeah, as well, preemptive genotyping tramadol can potentially lead to better pain control in South Africa. But these are all hypotheses that still need to be tested. And then there's a lot of evidence emerging for the cost effectiveness of preemptive pharmacogenomic testing internationally. This was a meta-analysis in 2022. They looked at 108 different studies, different medications that were assessed. 70% of the publications, they were able to demonstrate the cost effectiveness or cost saving. All of these studies were done in Europe, North America, none on the African continent, unfortunately. So this is evidence that's still lacking for us. But I think it will start emerging as access to this type of testing improves. Then you saw now on the previous slide the Clinical Pharmacogenomics Implementation Consortium. So this is historically something that has been a big barrier to the implementation of pharmacogenomics. That was a lack of standardized evidence-based guidelines. And that has changed now in the last 2 decades. So many international associations, including the US Food and Drug Administration, the Clinical Pharmacogenomics Implementation Consortium, CPIC, the Pharmacogenomics Knowledge Base, or PharmGKB, they now all provide evidence-based clinical guidelines for the safe and effective use of there we go. It's for the safe and effective use of medications based on genetic test results. So the FDA has now included PGX information in the labels of more than 200 different medications. And CPIC has released more than 23 clinical guidelines for over 40 different medications. And these are all open access, freely available. They're based on different sources of evidence, including preclinical functional outcomes, consensus information, and clinical trial data. And then the African Pharmacogenomics Network was established in 2018 with the aim of facilitating PGX on the African continent as well. So that was the first part of my talk. In this next part, I'm going to focus a bit more on the actual utility of pharmacogenomic testing. So how do you decide which patients to test? How should you go about deciding on a test or a testing laboratory? How do you interpret and apply the results that you get? And what are some of the important limitations that you should be aware of with this testing and inform patients about? So pharmacogenomic testing can happen at 2 different time points. Either reactively, that's where a patient has already started on treatments, they haven't been responding optimally, experiencing unwanted side effects. Or preemptively, that's before a medication is prescribed, with the idea that the genetic information that's obtained can then be used to make a personalized drug selection, the aim of reducing side effects and ensuring more effective treatment. And generally speaking, it's the preemptive approach that has the most potential benefits, although the reactive testing is probably still a lot more common. In both these scenarios, it's important to know whether the treatment that you're considering or that the treatment that the patient is taking has reliable pharmacogenomic evidence available to support clinical decision making. And you can contact your local laboratories to get that information, or you can access it on one of those sources that I showed earlier. So the CPIC website is one that I usually go to first. It's a very nice website with a lot of information. It has all the clinical guidelines that have been published. It has a lot of information on drug-gene associations and the evidence supporting those associations. And it also grades the strength of this evidence. So if you take an example, SSRIs or antidepressants, these are 2 guidelines that have been published by CPIC, one for SSRIs and SNRIs and one for tricyclics. These are all the medications that now have genotype-based dosing guidelines. So you can get more information on any of these medications on the site. If, for example, you wanted to know why fluoxetine is not one of the SSRIs listed there, you can search for fluoxetine on the site, and you can see they've actually assessed it in association with 4 different pharmacogenes. They've graded the level of evidence as C. So the CPIC grades levels of evidence from A to D, A being the strongest and D being weak or conflicting. And only levels A or B are regarded as strong enough for clinical actionability. So in this case, it was graded as C, and they explained to you why that was the case in the guideline that you can access there. You can also see the FDA label for fluoxetine to see if there's any dosing guidelines. And on the label, they also just warn that concomitant use of other CYP2D6 inhibitors can increase plasma concentration leading to QT prolongation, but they don't provide any of those So ultimately, you should consider testing any patient who's not currently responding optimally or is experiencing side effects from a treatment, provided there is robust high-level pharmacogenomic evidence or guidelines available for that treatment. And then any patient where you are considering a treatment where there is strong evidence available, and especially in patients who are diagnosed with chronic conditions who may require lifelong treatment for multiple medications. Preemptive testing will have the benefits of reducing side effects that may be difficult to tease out later if a patient is on multiple medications with overlapping side effect profiles, as is often the case. And especially in areas like mental health, cardiovascular disorders, pain management as well, because preemptive testing is really valuable. There may be some scenarios where testing can still be undertaken even where there's weaker evidence for drug-gene association. In these cases, the doctor should feel confident applying their own clinical judgment to the results that they get, and doing so in consultation with a pharmacogenomics specialist or a genetic counselor is always advisable. So once you've decided to have this testing done, where can you do so? So single gene pharmacogenomic testing has actually been available in South Africa for a while. A common example of that is TPMT, genotyping for thiopurines like azathioprine. So azathioprine causes severe bone marrow suppression in patients who have reduced TPMT enzyme function. And then DPY-D genotyping is another common example, fluoropyrimidines. But then more recently, panel-based pharmacogenomic testing has also become available in South Africa. AMPATH was the first lab to start offering this testing in the private sector. So panel-based testing allows for the testing of multiple pharmacogenes in one assay. So generally that has the benefit of being a lot more cost-effective. And in that example of the thiopurines, and second gene NUDT15 has now also been shown to impact on the risk of adverse reactions for thiopurines. So now you can test for both TPMT and NUDT15 in the same panel at the same time. So panel-based testing allows for preemptive testing so that pharmacogenetic information is available when prescribing decisions need to be made now or in future. And we know that a genotype is inherited, so it doesn't change. So that result remains valid throughout the patient's lifetime. So panel-based testing, as I mentioned, is currently offered in the private sector in South Africa and then also in the commercial genetic sector. Unfortunately, pharmacogenomic testing is not currently standardized. So there may be differences in the numbers of genes and alleles that are reported on between these different laboratories. The commercial genetic sector is also not currently regulated in South Africa. So it is very important to make an informed decision when choosing a testing laboratory or test. And here are some of the things that you can look for. So the first thing would be to have visibility of the actual genes and the alleles that the lab is including in the panel that they are doing. So as an example, a lab who is only testing for a few SNPs in CYP2D6 may be missing many relevant variants that can also affect enzyme function, copy number variants as well. And obviously reducing the number of SNPs would be a way of making a test cheap and marketable. So be aware of that. ISO 15189 accreditation is another good way of making sure you're using a reliable laboratory. So this is an international standard that demonstrates a laboratory's commitment to providing precise and accurate results and operating according to international best practices. So to maintain this accreditation, a lab is reassessed annually by an assessment body like SANIS. Note there are many different types of accreditation. Most of them have nothing to do with medical testing or genetic testing. So don't be fooled by a generic confirmation of accreditation. It has to be ISO 15189 specifically. And the reports that you get back will differ from lab to lab as well. Because of the inherent complexity in pharmacogenomic testing and the analysis of the results, most labs use third-party service providers for that analysis and for the clinical reporting. We do as well. So the reports that these labs issue can differ in terms of user friendliness and colorfulness. Ultimately, what is important is just that the lab that you choose has some pharmacogenomics expertise and support available. be it a pathologist or pharmacogenomics specialist, somebody who can assist and guide you, a doctor or a patient who first embarks on this type of testing. And then lastly is the cost, although I know this is usually the thing people consider first. Relatively speaking, the cost of pharmacogenomic testing is still expensive for most patients. We have seen improvement in reimbursement recently, although most of this is still coming from patients' savings and not from a chronic benefit. And then a lot of patients are also still paying out of pocket. So it is important to confirm that a patient can afford the testing that you are considering. Be careful of just going for the cheapest option. There may very well be reasons for that. Not that cost is a reliable indicator of quality. So at AMPATH, we do a targeted SNP array. It's a commercial Thermo Fisher assay known as the PGX120. So this assay targets 120 different genetic changes of SNPs, as well as copy number variants in 36 different pharmacogenes. So this is targeted testing. We do not sequence each of these 36 genes from beginning to end. And the reason for that is that we want to focus on those clinically actionable variants. So if you sequence the entire gene, chances are very good that you will end up getting a lot of variants of unknown significance, which in a research setting is great, which they can be explored functionally to determine what the impact of these variants are. But in a clinical diagnostic setting, we want to provide results that have clinical meaning that can be acted upon. So most clinical laboratories perform targeted testing for that reason. So it does mean that a patient who has a very rare allele, one that's not being targeted in a panel like this, will be missed. That being said, the PGX120 assay was specifically chosen because it also includes many of the alleles that are known to be more prevalent in sub-Saharan African populations, like those 3 listed there. And this is just a slide showing all the different medications that can be prescribed based on the results that you get from performing our panel. I'm not going to go through all of this, but just to highlight some of the common ones, the proton pump inhibitors, statins. For psychiatry alone, there's over 30 different medications. Pain management, NSAIDs, opioids. There really is a magnitude of useful information from performing a panel like this. As I mentioned, the reports that you get back from different labs will also differ, but generally they follow the same kind of basic structure. So usually in the beginning of the report, there's a table like this one summarizing the pertinent clinical findings for each of the medications in the panel. Our table looks like this. We categorize findings according to mild, moderate, and serious drug treatment interactions. So you can see in this example, the patient had a serious interaction for clopidogrel, lovastatin, and simvastatin. So then if you want to see more information on why this was the case, you can scroll down on the report. The drugs are all listed alphabetically. And then you can see more information on clopidogrel. So this patient was an intermediate metabolizer, which means this medication is going to be less effective for them. You can also see the source of the evidence for this recommendation listed there, and also the grading of the strength of that evidence. So pharmacogenomics results like that one can contain a lot of information, and it can take quite a bit of time to work through a report like that, especially when you have many medications to review. And that brings me to this point, which is how do you actually make use of all that information in a busy clinical practice? So we know that pharmacogenetics is just one aspect or one factor that influences drug response. Things like drug-drug interaction, liver function, kidney function, comorbidities, allergies, all these things need to be taken into account when making prescribing decisions. So precision prescribing cannot be based on pharmacogenetic information alone. And this is where something called clinical decision support software, CDSS, has become really useful. So this is software that is already available to doctors in South Africa. The Genexus platform is a web-based CDSS. So doctors can register for an account with this program. It's free of charge. Whenever they then have pharmacogenetic testing done for a patient, those results can be transmitted to their Genexus account. They can create a profile for that patient, upload any relevant clinical data, other medications the patient is taking, allergies as well. The software then provides a clinical pharmacogenomics report incorporating all that relevant clinical information. with recommendations for first-line treatments, with warnings for drug interactions. It's also useful to use in patients who haven't even had testing done yet. If you're not sure if a patient is going to benefit from pharmacogenomic testing, you create a profile, upload the information and the medications you're considering, and the software will then flag any medications where there are pertinent pharmacogenetic information missing. So this software was designed by medical practitioners, so there's a big emphasis on evidence-based recommendations. And yeah, this has been available since January last year. We've had some really good feedback from the doctors who have started using it. And then I'll just show you quickly an example of what the software can do. So this is the example I showed earlier. Let's look at warfarin this time. So warfarin was also flagged as having a moderate gene-drug interaction. And if you scroll down on this report, you can see this patient actually had 2 variants which result in a reduced response to warfarin, 1 variant which results in an increased response. So acting on this clinically would be very tricky without any kind of additional interpretation. So these results were then transmitted to my Genexus account. I created a dummy profile for Mr. Mickey Mouse. And this is the clinical features that I added for him. So he now has non-valvular atrial fibrillation, for which he needs anticoagulation. He's got some reflux disease, for which he uses esomeprazole. And then I gave him some mild renal and liver impairment, just to make this interesting. So the software then goes and asks a range of additional questions in terms of warfarin contraindications, lifestyle factors, the ethnicity of the patient, and then ultimately provides you with a clinical report, a 3-page clinical report like this one. So in this case, the software recommended a DOAG as a preferred first-line therapy. They give you options for different DOAGs. So it also warns you of any potential drug interaction. So in this case, there is a drug interaction between apixaban, Vigatran, and esomeprazole. And then if you still feel warfarin is the preferred first-line medication, it also provides you with a starting dose. So in this case, a 7 milligrams per day dose would be more appropriate as opposed to the standard of 5 milligrams. So this is just a quick demonstration. I think if any of you here or online need more in-depth demonstration, you can contact any of us or Tammy. I'll show you her contact details now for a more in-depth demonstration of this tool. So as is the case with any testing, and perhaps especially so with pharmacogenomic testing, because there's so much hype around it, it's important to be aware of the limitations and pitfalls. And especially so, expectations can be managed and inappropriate testing can be avoided. So as I mentioned, pharmacogenomic testing is not currently standardized, and there may be significant differences in the genes and alleles that are being tested for by different laboratories. So you need to make sure that the test you choose caters sufficiently for your patient and for the medication that the patient tends to take. There are still many medications for which there's either no reliable pharmacogenomic information or just very weak associations. And these can be tested for in a research setting, but ideally should not be done in a clinical one. Pharmacogenomics is probably one of the most active areas of research in medicine at the moment. So chances are if you do a quick Google search on any drug gene association, you will find a publication on it in the last 5 years. And this can become really overwhelming when you have to make a clinical decision on such select individual publications. And that is really where those resources I showed earlier, like CPIC, are very useful just to keep sanity in check. They weigh the evidence for and against drug gene associations in a scientific and an unbiased way so that appropriate clinical decisions can be made. So don't fall into the trap of acting on a variant just because a patient brings you a printed case study similar to theirs if there isn't sufficient additional evidence to support that drug gene association. And then also as a direct consequence of the amount of research being done, there's also a chance that guidelines and interpretations may change over time. Generally speaking, the strong recommendations will remain so, but the weaker ones may be upgraded or downgraded as results from new clinical trials emerge. So it's important to keep that in mind. If you have a report that's a few years old, it's a better idea to get an updated report. Software like Genexus is really useful for that because they do real-time interpretation based on current evidence. Then I mentioned the fact that African representation is still poor in pharmacogenomic research. This is important to keep in mind, especially if you have a patient sitting in front of you where the predicted phenotype just doesn't match what you are seeing clinically. And then lastly, to be truly meaningful, pharmacogenomic information needs to be available to all medical practitioners and pharmacies across the country. And the only real way to do that is to have it integrated with an electronic health record system, which is what a lot of countries are doing now abroad, the US and the UK as well. South Africa will need to start looking at the same thing. In the meantime, however, software like Genexus, I think, really help a lot in just making this type of testing more clinically useful and usable. So yeah, I think the evidence for the potential and the clinical value of pharmacogenomic testing has now been shown across many medical disciplines, and it's becoming essential for practitioners to be aware of this testing so they can inform their patients and guide them appropriately. We still have some way to go in terms of standardization implementation in South Africa. But I attended a CPIC webinar a while ago where the presenters actually mentioned that we should guard against the fact of the risk of infection being the enemy to good. If used appropriately, pharmacogenomic testing can already add a lot of clinical value to the management of patients for certain medical conditions. And then, as promised, this is just some of our contact information. So if you have any pharmacogenomic inquiries, you can use that pgx@ampath email group. If you would like a demonstration of the Genexus software or you would like your own account, you can email the Genexus group. And then Cami Hadaram is our pharmacogenomics specialist. She's also sitting here on the table next to me. She does pharmacogenomic counseling with patients as well. And she's also there to help doctors who need a bit of assistance with their patients' results and just interpreting findings. And that is it from me. So thank you. I hope I didn't overwhelm you completely. Happy to take any questions if there are any.
I just want to say first, thank you so much for the insight. I think we actually perhaps, I think up to now, really don't have so much information about pharmacogenomics. But first, I want to say congratulations for going the long miles to get to actually bring the knowledge to South Africa. That's quite great. And I think we need actually to learn quite a lot. But basically what you have presented here, telling you that actually probably in the next 10 to 20 years, if not actually next year, we should be moving toward more personalized medicine and actually trial and error kind of medication, where you just, and especially for medications that are quite very costly, it would be very nice actually to go all the way and make sure that you actually do the genetic aspect of it and make sure that you precise dosage. You know, we have seen that, I mean, in the case of patients with cystic fibrosis, we have one with the IV captive that currently we try to bring to South Africa.
Yes.
And what we don't know much, I mean, we know for the fact that there are quite a lot of pharmacogenetics that have been studied on the patients, and some of the patients actually, instead of paying so much medication for the medication, you could actually give them quarter medication and can have synergetic effect, obviously, like different antibiotics to make sure that it lasts longer and that reduce the cost. And my point of view in terms of respiratory medicine, I saw that most of the drugs there are more really for mental issues.
Yeah, there's a lot of psychiatric patients. Yeah.
So in terms of pulmonology, what do you have for us? Because we do quite a lot of patients. I mean, our current burden with disease in South Africa, I think we're looking more on airway disease from the asthma to COPD. And I think one of the key drugs will be the steroids.
Yeah, so the steroids, unfortunately, there's still very limited information on genetic information. That may change over time. I think it is dangerous to act on a weak association if there isn't robust evidence supporting it yet.
So the things that we can start looking to that in South African perspective and see how to actually use them, you know.
So corticosteroids, the long-acting beta agonists as well. There's one on our panel, salmeterol.
Yeah, so we do have one, but this is where the software also comes into play, is without having pharmacogenomic information on a patient, and if you use the Genexus software and input all the drugs that the patient is taking, it will still be able to throw out information on drug-drug interactions for your patient. So it can offer you some guidance, not genomic-based guidance, but in terms of, your drug-drug interaction.
Okay.
Yeah, so there's still that option of personalized prescribing based on clinical information and indications the patient is taking. I mean, once the pharmacogenetic evidence is there, you can start incorporating that into the decision making.
We do believe that the Trikafta at the moment is a Section 21 drug.
Yes, yeah.
So you guys are struggling to get it in the country.
I think there's ongoing meetings, but hopefully in the next 3 months, I think we should have, because they now, I think they have a meeting private 10 days with the state. And once that's done, we can also ask the private current patients actually go to Brazil to bring them over. And Discovery does reimburse it.
Okay.
The question that if you could actually submit more studies on it to see actually what really the good synergetic drug, especially genetic, because sometimes they say share kind of genetic linkage between there.
So there is very strong evidence for CFTR, which is a gene that is involved with the gating mutation.
Yeah, 519.
Yeah, 599.
Yeah.
So there is evidence. Unfortunately, it's not on our panel at the moment. There is a CPIC article. I actually have one here for you, or I can actually email you one that has very strong evidence in support of.
So you know, I was going to ask the question.
I mean, it's
So, but I'll email you a decent one, not one with all my scribbles on. But yes, there is very strong evidence in terms of that. I have chatted with the boss, and we have spoken about sequencing because we do CFTR as
so
well.
actually, I mean, when you diagnose cystic fibrosis, you're going to do CFTR sequencing.
Yes.
So as part of that, you can actually go and check if there are any of these drug fits.
So can we do that now? I mean, because we obviously most of us cystic fibrosis sequencing really we've done most with the AMPAT, and I think we do pick up quite. I think at what we have done currently, we pick up quite a lot of people above age of 50 years old. That have been missed through So, and we think that now they're having a lot of issue because one of the things that they have, they're sitting between cystic fibrosis and hypoglycemia.
Mhm.
And then of course they develop these recurrent infections and you don't know which one comes egg or chicken, you don't know. So now we wanted to start this people medication. And perhaps maybe once we send those tests, it would be nice to actually have a look, make sure
Especially
that,
for the gating mutation, because that's where the Trikafta is prescribed.
and see whether it's going to work actually or not.
Yeah, I mean, we've got a lot of data on cystic fibrosis. In fact, I think that's another talk we should do here one morning.
I think we need that actually. Yeah, I think that would be very nice. Maybe one of you got actually Michelle. I think I'm posing it now. Look, I think that's what the platform is. To allow people to to hear the new. We don't want it to the usual, but we wanted, I think, education for doctors who really want to learn a lot. But I think there's just so much learning stuff and context.
Yes, and we've got a genetic counselor who's doing her PhD on cystic fibrosis, so she would be very interested.
Okay.
To talk to you.
Wow, that's quite amazing. So in terms of antibiotics, anything? Because I think also it would be very nice to, just knowing which one to prescribe. And, imagine somebody walks in and you say, okay, great. I mean, obviously one of the things I want to ask you is about the time, the durations. Is it quick results?
So at the moment it takes 10 days.
10 days.
But obviously, if we know this urgency, the patient needs to go for a stent and they have to have the topic over results, we can prioritize and try and.
Yeah, and actually could actually.
Sooner. But that's also one of the reasons why for instance, you have that information already.
But ideally, every action should have it, should be like a number plate of a car, isn't it? You should actually have your genomic kind of profile, with all the genomic sequence. And when you go to your doctor, you just say, listen, this is what I have. This is what you can prescribe for me.
Hopefully the doctor knows what to do.
And that's why we're there to help. That's why we're there.
No, but it would be very nice. Maybe I should do my own, just get all my genetics sorted out and even the family and just say, okay, great, you have upper respiratory tract infection. That's what you can do. That's so much with this. Otherwise you're going to get toxicity.
Yeah. But no, on your question on the antibiotics, there aren't many. Do you have testing available? It's more for things like adverse events like clindamycin induced hearing loss. So that's also not a gene that's on our panel. It's a mitochondrial gene, so you need a specific dedicated test for that. But those are the things that's limited in antibiotics. Most of the testing there would be to determine resistance, where you would need to sequence the actual bacterial genome to determine what resistance there is.
So basically you're saying that actually there's so much potential for those who want to further their studies to kind of look into that, isn't it?
Yeah.
Yeah, I think so. It's actually a very good thing.
Yeah,
Panel? Anything you want to add? Yes, yeah, George?
I just wanted to ask, how do you decide on your panel? Okay, like in the sense you want to test, so it's specific to the question. So what are the different, so these are different panels, for example, or is it just the
No,
drug?
so this is one assay,
It's one assay, so
All-
everything,
all
all this
6 genes
information
are
with one
tested.
patient.
and you get all of that information.
And how much that
cost?
cost?
So it's 3,200 rand.
Oh, can that come from mine?
Yes.
I'd like to do mine. I was so.
But does it tell you, for instance, if a patient, let's say the patient has now a high affinity for side effects to atorvastatin, but the patient is on atorvastatin without any effects?
Then I would still make my decision based on the clinical picture. If the patient isn't experiencing side effects and they're well controlled on atorvastatin, I wouldn't change management just because you get a result back like that. But obviously, if you're considering changing the patient for some reason, either their side effects or they aren't well controlled, then the report will give you some guidance in terms of what is the best second option to consider in such a patient.
But also, I think isn't the biggest question you need to ask yourself, okay, great, you got that potential, then maybe, yeah, I mean, in the really clinical setting, then you look, ideally, you must do the drug level. Now, and that will tell you maybe perhaps if you're 20, you're fine, but if you're on 80, well, that's where the problem comes in, isn't it? Because it becomes very specific, because it's not really looking at genetic aspect, but also see what are the dosage. I think they fall concurrently, isn't it?
So the risk with the statins is the SAMS risk. So the skeletal muscular, issues that the patient has because the statin builds up in the muscles. And that is where the gene SLOCO1B1 plays a big role because, it allows for the transportation of the statin to the target, etc. So that is where the genetics comes into play. And patients might not always tell you, yeah, I've got cramps in my legs or whatever, but those are usually the early signs and symptoms. The statin buildup.
And you actually see some patient with they're having this issue on 10 milligrams, others having it when it's on 40 milligrams, and I think perhaps that's where the problem comes in, where maybe we need dosage for personalized kind of dosage for particular individual based on their genetic profile.
Because you see, the problem is the patients who actually need statins are the ones with the most issue with statins because of media. People don't want to go on statins. I don't know what. They will take a handful of homeopathic medication.
Yes.
But then you ask them, but why don't you want to take your statin? No, I've heard it's bad for you. See, that's the.
A few consultations with patients recently where they literally stopped taking the statin and then taking Sutherlandia and all these other homeopathic medications. But it's because they're starting to believe that statin-induced diabetes and with all the statin-induced side effects, I think there's
So many misinformation out there.
There's one study here and one study there and, that sort of thing. So, but that's where it's important to sit down with the patient during a pharmacogenomic consultation and explain to them about the herbal drug interactions and, taking the Sutherlandia is now going to hamper healing, for example, that sort of thing. So then you see the light bulb moment. And they're like, maybe I must stick to taking my statins and maybe speak to my doctor about a reduced dose.
I think that's the problem with the studies, because most of the herbal medication are not studied. Everything, it's natural, no issue, and all those, which is actually,
It's not sacroregulated.
which is not, exactly. And I always tell the patient the fact that I don't prescribe it means probably it's not beneficial, because I think there are just a lot of things coming out with the gap in the knowledge.
When is hematology going to be properly represented?
Yeah. At the moment we have warfarin basically.
And
Anytime.
it's warfarin's on the way out anyway.
So unfortunately, we couldn't use it for the DOAGs.
But the problem is warfarin, most of my patients still need warfarin. That's my problem.
Is there an alternative?
They can't afford.
Yeah. So I think that's one, and then the other one is ARVs.
Yeah,
Especially in our setting, we have a lot of patients on ARVs and other medications.
So ARV pharmacogenomics, when we talk about efavirenz and things like that, so we have efavirenz on the panel, that's a 2B6, but efavirenz is being phased out.
Yeah.
However, there is strong evidence in terms of certain genes like the UGT1A1 and things like that, for certain of the HLA, especially also for their BACABA, for example. Unfortunately, we don't have those genes on panel currently. That's the only issue. We are looking at customizing a panel in future, to
We do
cater
the back of the testing
separate. Yeah.
at the moment.
Even not, I mean, most of the ARVs is Stoltiga
Yeah.
related. All of them. So
Yeah, that's UGT 181.
Good morning, guys. Online, any questions? We haven't forgotten you.
and the-
I don't know if there's a chat that I need to check maybe.
Oh,
and then the other
Yeah, no
ones that's
questions. Good morning, everyone.
Thank you, Collie. He's a physician at the High Family Clinic. Thank you for joining us. Manda?
Thank you.
Thank you.
And I think that the biggest shift now in medicine that I've seen is diabetic medication. So it is GLT2 inhibitors, and then the new injectables like Ozempic and Mounjaro. So, yeah, because that's the way everything is
You got
going.
mutation about Ozempic, so you can't use that.
Sorry?
You don't use Ozempic because you got mutation. Okay, I think maybe we should do a genetic test for now.
But as Dr. Alant mentioned, that evidence keeps growing in support of genotyping for certain drugs. We'd be adding the drugs. So the list that you've got, or the list that both of you have, is a list of drugs for now. In 6 months' time, there might be additions to the list.
How easy.
It's not about it being easy to add. So what we do is when we look at the drug list, we look at ones that have high levels of evidence strength. So Dr. Alant spoke about the CPIC grading. So we only look at levels A and B. We try to include information that's actionable within your clinical setting versus giving you a 50, 100-page report of informative, things that may help you.
The reason I ask is that I've got a patient who's on chemotherapy, who's on antiemetics, who's on pain tablets, who's got a clot, and is on anticoagulation. I mean, this is a patient with everything. You can
Polypharmacy.
So this would be beneficial to me if we can.
So let's try that
Yeah.
question on the sample and see what they recommend.
That's what
Based on the lecture, what's really given here that, look, this is a very beautiful test, but sometimes I think because most of the physicians, especially in South Africans, are not aware of it, so you really have to have somebody to interpret it. And it's kind of the multidisciplinary approach to make sure that actually you get the best out of it. And I think it's not really expensive, 3,000 Rand as compared to this cost of side effect action that you have to
So what
anticipate.
you can do is you can email me a list of medication that the patient is on, and I'll be able to tell you what we cover for. But together with the software, we will be able to give you some sort of clinical guidance in terms of your specific patient. So I assist the doctors with interpretations, and we try to figure out a way to get it out.
So thank you so much, guys. We have lovely coffee here, and it wasn't possible without Cara.
It's a pleasure.
Cara, the floor is yours. You want to say something to us?
Thank you. Good morning, everyone. Should I stand that side?